Welcome to the latest edition of Exploring Health with Cleveland Clinic London. I'm your host, Kash Akhtar. I'm a consultant orthopaedic knee surgeon. And in this episode, we are navigating hormonal health across a woman's life journey. Millions of women around the world suffer, often in silence, due to underdiagnosed and undertreated conditions such as endometriosis and menopause. And so today we're shining a spotlight on these conditions by bringing together two experts in these fields to unpack two of the most misunderstood health issues affecting women across their lives. Joining me today are two of my colleagues here at Cleveland Clinic London, Dr. Joan Pattle, a general practitioner with a specialist interest in female health, and Mr Arvind Vashisht, a consultant gynaecologist. Welcome. Arvind, do you mind kicking us off? Could you just start by explaining exactly what is endometriosis and why do people say it's often misunderstood?
Well, I think that you've already highlighted two of the issues with endometriosis, which is failure to diagnose and then an array of different treatments that are often started quite late. To take a step back, endometriosis is essentially cells that are similar to the endometrium, which is the womb lining. And this is during the reproductive cycle. This womb lining tissue sheds itself every month, and this gives what's known as the menstrual period or the withdrawal bleed. And endometriosis is where cells similar to those are found outside of the uterus, most typically perhaps around the ovaries or around some of the supporting structures to the womb, the ligaments or the bowel or the bladder. And then in the same way, like a woman has a cyclical bleed, those areas also get inflamed at various stages during the cycle. So that's the condition of endometriosis.
Right. So there's a recurrent inflammatory process on a monthly or so basis?
Yeah, I think that probably encapsulates it well, that there is this, initially there is this monthly cyclical pain or inflammatory process that kind of goes on that I think is probably at the heart of many of the women's symptoms.
Right. And as you're saying, it's spread throughout the abdomen. And so how does it fundamentally affect women?
So a number of women may be relatively without symptoms. So actually the occurrence of endometriosis that may be picked up on scans or incidental findings during surgery, they may not have much in the way of symptoms, but they would almost certainly represent the significant minority of patients. And for others, and for the majority, there's a familiar cascade of what may be described initially as painful periods. There may be pain on intercourse. There may be pain on bowel function, on bladder function. And sometimes, dependent on the longevity of these symptoms and, of course, where the disease is thought to be, this can then set place in terms of becoming a chronic pain type syndrome as well.
Got you. And Joan, just out of interest, how does endometriosis present in primary care? What things should people look out for?
Well, I think Arvind, as he said, they get cyclical pain during their menstrual cycle and pain during intercourse. And I think one of the interesting things that I see with women is that they sometimes expect to have pain with cycles. It's something that you think as a young person is just a normal part of having a menstrual cycle, or they normalize it. And so they don't realize that it isn't necessarily normal to have that. I mean, there are some low-grade pains that you might get with your cycle, but more extreme pain should be investigated. And I think a lot of people don't necessarily know that and go to the doctor and talk about it.
I'm with you. I'm just trying to understand what the daily impact of endometriosis is on personal relationships, on life, on work.
Some women who are so affected actually have to take time off work. I had a recent patient who was taking 2 or 3 days per month off work because of her endometriosis. Obviously, that affects your personal life. You can't go out and do things. It can affect your relationship because of the pain with intercourse. So the impact can be quite significant.
Okay. Now, Arvind, I was wondering, what are some of the hallmark symptoms that you see in clinic that people often ignore or misattribute?
I mean, there's so much about what Joan said as well in terms of how patients may present. And I think some of these key starting points are the normalization, not just of the poor suffering patient themselves, but often by primary care physicians, by gynecologists, by medical staff, accident and emergency staff. There may be, there's a familiar theme of many of these patients really struggling to get a diagnosis. So either a dismissal of the symptoms or an ignorance of the underlying causes, or that there may be a diagnosis such as endometriosis. So we often find that women, by the time they actually see a specialist, may well have taken a very meandering path through admissions in accident and emergency, trips to the GP, and as well as those typical symptoms that we mentioned before that are the clues to the condition, there are then the knock-on effects, as you also mentioned, in terms of personal relationships, in terms of professional relationships, ability to miss days at school, miss days at work, general interferences with quality of life. So these symptoms evolve through the passages of time and can certainly be often very scarring, very detrimental. And so by the time that they actually come to a specialist, it may be that they are some way down the line with the symptoms that they've suffered.
I guess from the way you said that it can spread amongst all the organs within the abdomen, bladder, ovaries, what have you, I guess on that basis that the symptoms can be quite disparate. It's not always one set of symptoms and they can have different effects. And so they may end up seeing their GP. Some people go to A&E or the ED if they're in severe pain, may get dismissed. And so that's why you're saying that there can be a psychological impact as well of getting a diagnosis.
Yeah, you're right there, Kash. In fact, that there is, in part, potentially because endometriosis involves other organs and other body systems, in part because it can be part of a chronic pain syndrome. There may be multiple crossovers with different specialties. So it may well be that a patient might present to a bowel surgeon or a gastroenterologist or a urologist with some of the symptoms of endometriosis. But again, this comes down to awareness, investigations, and thinking about endometriosis.
Can you tell us then how it's diagnosed?
So there are many different ways of diagnosing, and some of it, as I say, is an understanding of it being a possibility. So that's being in the patient's mind as well as in the treating healthcare professional's mind, that this may be a possibility depending on what those symptoms are like. And then what we tend to use is some form of imaging. So that usually would be an ultrasound scan or in some cases an MRI. Now, whilst they may not pick up all cases of endometriosis, they often may pick up certain, again, telltale signs of endometriosis. Now, unfortunately, some of this is very much operator dependent. So there's a repetitive theme in what I'm telling you about awareness, knowledge. So even those people doing the scans need to be able to read and look for the telltale signs of endometriosis. So part of what I'm trying to do is actually spread that word about improving diagnosis and setting standards nationally, for example, for ultrasound scanning, to try and pick up that diagnosis. And historically, the gold standard way of diagnosing has been at the time of a laparoscopy. So that's an operation where a camera is inserted into the abdomen under general anesthesia to look for those areas of endometriosis. But that's an invasive procedure, not without its particular risks. So I think that the way forward is to try and push on some of those non-invasive tests. So as mentioned, it's the radiology ones. And actually there's a growing market in people looking at even less invasive tests. So salivary tests, gut function tests that might give us clues to a possible underlying diagnosis of endometriosis.
Are there any hormonal blood tests that you do?
At the moment, there's rarely a reliable diagnostic blood test for endometriosis. And certainly there's a lot of research going on in this regard. But really, with any test, you need it to be sufficiently good at picking up the people who actually have the condition, but also not for example, over-diagnosing patients who don't have the condition. So that's all about false positives and negatives, and we're not quite there yet with endometriosis and hormones.
Understood. And you mentioned the salivary tests. Are there any newer emerging diagnostic tools that may speed up the diagnosis or give us more accuracy?
Yeah, so I think it's really good that we're looking at non-invasive tests. I think at the moment, I don't think the evidence is there to thoroughly endorse any of those tests at present. But this is a very rapidly evolving field, and I think those tests will get better and better. But for the time being, I think that the way that I see things, I think that the chief way is to try and improve some of those radiological ways of diagnosing endometriosis and getting the clinicians who are doing those to be properly educated and informed into the clues that there may be endometriosis present on the images they're looking at.
And which, as you say, comes back to awareness.
Absolutely.
Can I ask, how does endometriosis affect fertility?
So again, for some patients, they will have endometriosis and have no problems at all falling pregnant. So I think that there's almost enough difficulties that come with a diagnosis of endometriosis, not to necessarily add fertility as a key chief problem for them as well. But that being said, we certainly know that women with endometriosis do unfortunately have lower fertility potential to women without endometriosis. So I think that it forms part of the discussion that anyone would have with a woman when she's being diagnosed with endometriosis, talking about possible fertility implications. And again, that depends on having a holistic view of the woman and depending on what stage she's at in her reproductive life, what her treatment wishes are, and where she's at with respect to that. And to elaborate on that in kind of greater detail, as Joan's mentioned, and as we discussed before, just simply by virtue of endometriosis potentially causing intercourse to be more painful, might just by, in relatively simple terms, make intercourse less frequent and therefore less able to fall pregnant. But we also know that elsewhere in the pelvis, these deposits of endometriosis can cause organs to stick together, can cause fallopian tubes to become blocked, and these fallopian tubes are really the key transition points for the sperm and the egg and for fertilization. So those all become ways where endometriosis may impair future fertility.
And I guess that's the time where, if you find there's challenges, is that when you would talk about fertility preservation strategies?
Yes, and I think fertility preservation strategies kind of cross many different other conditions. So endometriosis, adenomyosis, there are lots of women who have unexplained fertility. Again, what's happened in the last 10 or 15 years is that there have been big advancements in what's possible for women in terms of fertility preservation. And as well as the anatomy, where I've said that things may be stuck together, there may be impairment of the ovaries and ovarian function. So we know that when you have endometriosis within the ovary, which is called an endometrioma, there may be impairment of ovarian function. So again, women may need to consider methods and supportive measures such as ovarian or egg freezing. That all forms part of the discussions and all very much geared up towards the individual patient who's in front of you and working out what the treatments tried have been and what the treatment goals are.
Thank you. That's really helpful. Joan, when it comes to seeing endometriosis and treating it in primary care, is it something that you would treat or is it something that you would refer on?
I think if I suspected endometriosis, I would refer it on because it does need that specialist imaging and input. I mean, one interesting thing as you were talking, Arvind, is, what we see a lot is women who've kind of, been treated somewhat. So they've been given pain relief, or then they've been given birth control pills to kind of control the endometriosis or the cyclical pain they've had. Is it a disadvantage to them that they've sort of, used that treatment and have delayed perhaps their visit to the gynecologist? Will that have a future impact on their fertility? Is it better to get them in sooner or try to treat simply in primary care?
No, I think that it doesn't disadvantage them, Joan. I think the key is always having a sympathetic and an understanding and a knowledgeable healthcare professional who's looking after you. And that's not the exclusive domain of a gynecologist. And often that treating gynecologist may be doing exactly the same things that a primary care physician may be doing. So I think that it's all about the knowledge, the understanding, the empathy, and also it's always, and I've mentioned it before, about the patient-driven goals. So, for example, if somebody has been trying to fall pregnant, then actually there is much more of an incentive to refer on. If many of the measures are not currently working, then that's an incentive to move on to consider surgical options. But actually, I don't think it's a hindrance to certainly start treatment, which again forms a whole holistic pathway, which often primary care physicians are very well placed to start some of the some of the neuropathic type of pain relief that might be around there, and starting hormonal treatments.
So we ask about the medical treatment, the non-surgical. You've touched on a couple of things. Could you just give us an overview of that, please?
Yeah, so again, if we go back to what you said before, Kash, and you summarised it very well, of saying that this is an inflammatory type of condition, I always try and explain that the real aim of treatment is to try and ramp down some of that inflammation. And there are many different ways of doing that. And I'm fundamentally a surgeon, and so I would potentially be looking to remove some of those endometriotic deposits that we think are beacons, or some of the things that are emitting a lot of that inflammation. But we know that surgery doesn't suit everybody. Not everybody wants surgery, and surgery isn't successful for every single patient. So there have to be other considerations within that. So outside of surgery, again, the mainstay of what gynecologists might get involved with is generally some form of hormonal manipulation. So rather than having the undulating ups and downs of the woman's normal menstrual cycle, hormones pretty much come in there and say, we're taking over and we're not going to give you any ups and downs. We're just going to give you a steady stream of hormones. And that steady stream tends to be less aggressive or less inflammatory for those lesions than the ups and downs of the normal cycle. So those are the, let's say, the key gynecological or medical approaches. But then there's a whole host of other things which are ways of just turning down the noise in the pelvis, which is neuropathic agents, and other forms of simple pain relief that are often used there. Also, there's questions of inviting pain medicine specialists who work on an array of different ways in terms of a whole host of different medications that might be used. And then, of course, there's we often are very reliant on physiotherapists who've got various manual handling techniques or muscular relaxation techniques that many women find really beneficial, helping with other symptoms like general pelvic pain, problems with intercourse. And then many of my patients may be seeking out dietary interventions. They seek nutritional support. And within that, whilst we're not taught that at medical school, certainly have a kind of growing interest in a belief that there might be certain foodstuffs that are generally a little bit more pro-inflammatory than others. And actually just listening to patients kind of tells you there's a whole host of different treatments out there that some people really swear by.
Right. And when you talk about managing the hormonal noise, as it were, is that through oral contraceptive pills? Is it from stopping periods and hormonal fluctuations? I'm just trying to understand what medications one might prescribe.
Yeah. So at its simplest, it is the equivalent of the contraceptive pills. So what they're doing is they're manipulating to a certain extent ovarian activity.
Right.
And a lot of women get very concerned about saying, look, this is going to be masking my symptoms. And whilst I'm sensitive to that, sometimes it provides a useful stopgap for them to kind of just give them some respite of their symptoms. But often those tablets may take a few weeks to work. So generally I'll try and tell people, look, you might have some side effects that usually can be transient, but try and bear with them and try and get the 6 weeks of initiating treatment. Unfortunately for many women, they may really struggle with some side effects. Thankfully, there are many different types of hormonal preparations that are out there, but a lot of women may struggle with some of the mental health side effects with things, may get some breakthrough bleeding with them. But usually we can try and work through them in a considered fashion. And of course, this is an evolving field, so there are newer preparations that are coming out all the time.
So that's the medical management.
Yeah.
And then the surgical management is to basically reduce the burden, as it were, the endometriosis load. And that's done through laparoscopy, keyhole surgery?
Yeah, so I think that over the last 20, 25 years, there's been a big change in gynecological surgery, so that we've moved away from open surgery to keyhole surgery. So the vast majority of endometriosis surgery will now be done through keyhole surgery, laparoscopically, or actually increasingly now through robotic surgery.
Right. And are there ever extreme cases where one might have to remove an ovary or a fallopian tube if someone's really struggling?
So again, the surgery is very much tailored according to the patient's symptoms
Yeah.
as well as their treatment wishes. So at one end of the extreme and the most extreme surgery, we may be doing things that do involve removing organs, removing the womb, removing ovaries, and even sometimes removing areas of the bowel or the bladder. And whilst all of those things feel like huge extreme steps, for many women, they ultimately represent a welcome relief from what has been decades of significant symptoms. But more often than not, surgery's pitched at being a lot more conservative than that. And going back to what we said originally, we really rely on the value of preoperative assessments, so that involves having images looked at by experts, so that almost before we do our operation, we know already what we're likely to see inside. We've had the conversation with the patient about what her surgery may entail. And most importantly, also, we've assembled the right group of surgeons, because for certainly the most complex forms of endometriosis, this isn't just something that a gynaecologist deals
You
with.
may need a urologist or a bowel surgeon.
Bowel surgeon, a urologist, and sometimes even we use surgeons who are skilled in operating in the chest as well, and thoracic surgeons.
Right. So one of the advantages of doing that in a place like Cleveland Clinic London is that we have all those specialties in-house. And I'm trying to understand, because I imagine around you there's quite a big multidisciplinary team of many people. Who's in the team here at Cleveland Clinic London, and how do they support women with these complex endometriosis cases?
You're right that at Cleveland Clinic London, we have the luxury of an assembled group of experts who are familiar and aware of the condition. So again, if we fast track back to 10, 15 years ago, we were reliant on colorectal surgeons who weren't particularly familiar with endometriosis. We would call them in the middle of operations, and then they would try and treat a condition that they weren't terribly familiar with, and weren't absolutely certain about the patient's treatment wishes or the patient's symptoms. So bring that forward, and we've learned a lot within gynecology. We've learned a lot in women's health about assembling these teams of involving those right people beforehand. And so they're involved with the whole pathway very much from the outset. So most typically, it may well be that, as we said with Joan, that the patient may initially present in primary care. You'll pick up some of the potential warning telltale signs, end up seeing a gynecologist. We'll do the imaging, and then on the basis of the symptoms and the imaging, we will either suggest that maybe perhaps the patient needs to go down a pain management pathway, or see a gastroenterologist, or see a physiotherapist. But once we start getting into planning surgery, then we do get those key members such as the urologist and the colorectal surgeon. They will see the patient preoperatively, so that actually there is an awareness of the patient's symptoms. Patients had all the opportunity they need to discuss all the nuances of certainly what can be quite radical bowel surgery, where we sometimes take away areas of the bowel, so that the patient becomes familiar with that, well prepped, an opportunity to ask every single question going that they may have, and then culminating in a final decision thinking, is this the right thing for me? What can I expect from the operation? What can I expect from my convalescence?
When we talked about the delayed diagnosis and a lot of the chronic pain elements that can arise if someone's had symptoms for 5, 8, 10 years without a diagnosis, been to lots of down different alleys, I imagine there can become quite a strong biopsychosocial element to it. So do you involve psychologists as well?
Yes, so I think that sadly, in many aspects of healthcare, psychology is underrepresented in terms of resources for patients. I know that from the kind of NHS hospitals that I work in, as well as in the private sector, that actually psychologists are often key parts of this process for all the reasons that you've said, but actually are very underrepresented. So if we feel that there is a strong psychological component to things, or if the patient feels that actually that's the route that they initially want to seek out, then we'll refer on.
Gotcha. Thank you. And Joan, what do you wish that more GPs understood about managing this condition?
Probably one of the main things is really recognizing it and recognizing the impact. Um, women present with all different kinds of pain conditions and sometimes vague conditions. And I think it's really, really important that they recognize the possibility of endometriosis and get them referred as soon as possible. And, start initial treatment and then get them referred.
Okay, thank you. So in the introduction, I said that in this episode, we'll be navigating hormonal health across a woman's life journey. And if endometriosis dominates the hormonal conversation early in life, the menopause reshapes it later. So Joan, I'll come to you. Could you tell us what is menopause and fundamentally, why does it happen?
Okay, menopause is defined as not having a menstrual cycle for 12 consecutive months. But the reason that it happens is that our ovaries produce 3 different hormones: estrogen, progesterone, and testosterone. And in a woman's early life, those are on the rise. That's puberty. Those levels then tend to be stable for a couple of decades, and then they start to fall. And that tends to be around the age of 40, and then tends to then get stable again at a lower level. The average age of menopause is 51. And during these times when the hormone levels are changing a lot, so in puberty and in menopause, is when she might feel a lot of symptoms that can be very, very extensive. So she might have a whole sea of symptoms that include brain fog, cognition effects, new migraines, effects on her skin and hair, hot flushes, night sweats, which are very common menopausal symptoms, poor sleep, menstrual change, of course, lack of libido. So there's a whole host of symptoms. Not everyone gets all of those symptoms. Some women just sail through the menopause with little trouble, and others are really, really burdened by it. But the main cause of it is this change in hormones as women get older.
Are there any symptoms that people are surprised to learn are related to hormonal changes?
I think, it's probably more commonly known that you'll have those symptoms related to your reproductive system, because I think we all think of those hormones as reproductive hormones, which they are. But things like joint pain, weight gain, even brain fog, those are sometimes hard to very, black and white attribute to the menopause. The other thing that's happening in this time period is that there could be other chronic health conditions, there could be lifestyle effects that all would contribute to a similar set of symptoms. So it's difficult sometimes to know exactly what we can attribute to menopause and not.
I'm with you. And so that's the thing that you as a GP in primary care have to pick apart, because people come to you undifferentiated with any kind of symptom of any, and it could be arthritis for their joints.
Right.
Or it could be something more significant than that.
I mean, even symptoms or conditions such as hypothyroidism, that could give you a lot of similar symptoms. And so it's really important to get the full story, understand the set of symptoms, the onset, and do some tests to make sure that we're not missing any other chronic condition that could be contributing.
Got you. And let's talk about the diagnosis and the tests. I'm assuming some of those tests are to exclude other things like hypothyroidism, checking people's thyroid function. Is there a standard set of blood tests or investigations that you would do to diagnose menopause?
So this is such a hot topic.
I'm glad
and
I
this
asked.
This is such a common request that women want to, they want to have the blood test to diagnose menopause. And for women who are on certain coils that make them not have a period, or if they don't have a uterus, it's sometimes hard to know if they're in menopause. Some symptoms are obvious. So if they're having night sweats and hot flushes, it's probably pretty obvious that they are starting the menopause or they're in the perimenopause time period. So yes, many women come to the room asking for blood tests to help diagnose menopause. And sometimes that's very helpful if they're currently not having periods because they're on contraception of some sort, or because they've had a hysterectomy and they don't have a womb. So in those cases, it can be very helpful. So blood tests, the issue with them is that your hormones change throughout the month. And even, when you're in the perimenopause, you could have surges of hormone and then it goes down.
Right.
And so it's not a very defined diagnostic tool. There's a hormone called FSH that if it is very high, we suspect that a woman is in menopause.
Okay.
So it can be helpful, almost more as an additive kind of test to do, rather than purely diagnostic.
So just so I understand, would you normally do blood tests if someone came with querying whether they're in the menopause, or would you base it on their symptoms?
It would depend on her age and her symptoms. So if
Right.
it was a young person, I'd say somebody, around the age of 45 and that kind of range, I probably would do blood tests just because it would be helpful to know what her FSH was and what her estrogen level was.
Right.
If somebody was older, sort of 50, classic age for menopause, and was having classic symptoms, I would say she doesn't need to have a blood test.
Got you.
Yeah.
And the one thing that is interesting, just as someone who's not involved in this field at all, I'm hearing more and more about menopause, and it's definitely become a lot more talked about.
Yeah.
You see it in newspapers, on TV, talk shows, in a way you don't quite so much with the endometriosis at the moment. And so I think there's more of an awareness about menopause now, isn't there? So I think people have an idea of what it is. And I'm assuming more and more people are seeking out consultations with you about the menopause.
Yeah, and I mean, it's fantastic that there is so much more information out there about menopause. There are treatment options that are talked about. There's almost a whole industry around menopause. That's really helpful. It makes women feel confident in coming forward to their healthcare provider and coming to try to get treatment. Sometimes when there's so much information, it can almost be confusing.
Yeah.
Because there's lots of sort of alternative therapies and things that are sold to help menopause, and some of those have evidence and some of them don't.
Right.
So it can be really confusing for women.
I'm with you.
It can be confusing because it's not like some of the other areas of medicine. For example, if you had a sore throat, last week you were fine, this week your throat hurts. The symptoms of the menopause come on very, very slowly. You can almost look back and think, gosh, last year I didn't feel that way.
Yeah.
And they can change. So you can have periods where you have a little bit of joint pain and weight gain and a bit of brain fog. And then you have more predominant symptoms of hot flushes and night sweats. And so it isn't a definitive constant set of symptoms necessarily.
I'm with you. And it sounds like the thing that complicates diagnosis of endometriosis and of menopause is the fact that it's hormonal, that the multiple hormones, that they impact on virtually every aspect of the whole body, and it's cyclical. And so as a result of that, it's not a one set of symptoms or presentation, it's different every time.
Exactly.
So you touched on treatment options. The big thing in my back pocket is HRT. But just before we get to HRT, you mentioned that there were some alternative methods. Some have evidence, some don't. Is there anything how would you go about treating someone who you've now diagnosed as being menopausal? How do you think about it, and what kind of steps would you instigate?
Yeah. Well, I think treatment sort of comes in a couple of different categories. So there's medical treatment through HRT, and that's simply replacing the hormones that have declined. There are some non-HRT medical treatments.
Okay.
So there are some women who can't take HRT because, for example, they've had breast cancer, or they have a significant risk of blood clots. And there are medicines which can really help with those, what we call the vasomotor symptoms, the hot flushes and night sweats. The other really important bucket of treatment, if you will, is lifestyle.
Yeah.
And I think a lot of people think, oh gosh, that doctor is telling me to exercise and eat well again.
Yeah.
And some of these things really, really help.
It impacts virtually every aspect of life and health.
Absolutely. On the lifestyle front, so exercise is really important. It helps your sleep, it helps with your weight, it reduces your cardiovascular risk, it makes you feel good. I think women at this time period really need to prioritize sleep. I mean, gone are the days of the 30s where you could, sleep when you die. It's more of you really need to prioritize sleep because it's harder and harder to get. I think eating well with good protein intake is very important for women at this time because they're also concerned about their bones, their bone density, and building muscle. Reducing alcohol is also very, very important. That can encourage hot flashes. It can affect your sleep. We know it's a carcinogen and it's very bad for you anyway. So I always encourage women to really cut down on the alcohol. And then the hardest area, I think, is just managing stress. there's a lot of things that are going on usually in women's lives at this point.
I'm just thinking.
They've got different generations to look after. And I think it's really important, sleep and exercise comes into that, but also just being boundaried in your commitments. And, there are simple things like that really make a difference.
Which is not always possible for everyone, but I fully understand what you're saying. Self-care is a very important thing.
I think sometimes it's funny, if a doctor tells you, almost gives you a license to say, be boundaried.
Yeah.
That's fine.
Yeah.
It makes them feel better about possibly doing that.
Yeah. And when we talk about HRT, hormone replacement therapy, it comes in various flavors in terms of what are the hormones in it? And I if you could just tell us that. And my understanding from medical school days, from a long time ago, is that you can change the ratios of what's in there.
Well, that's I'm impressed because there wasn't a lot about this in medical school, at least when I went. But so the hormones that we replace are primarily estrogen. We then use, because estrogen has this, as Arvind has talked about earlier, this cyclical effect, and it builds up the lining of the uterus in preparation for a pregnancy. That's one of its roles. We have to protect the uterine lining so that doesn't build up too much, because that is a risk factor for endometrial cancer.
Right.
And so we need to use progesterone so that there's no risk of endometrial cancer. But by replacing the estrogen, I think that is the thing that really helps women feel a lot better,
right?
Because that is the hormone that has multiple effects all over the body. Women also get benefit from having the progesterone. That has a mild sedating effect, so that can be helpful too. Some women really benefit from having testosterone. Its real licensed use is for women who have particular issues with libido, and it can be very helpful for that.
Okay, thank you. And is there a right time to start HRT?
That's a really interesting question because, I'm finding that people, I don't know about you, Arvind, but younger and younger women who've heard about the perimenopause and get those initial symptoms want to get on the HRT straight away. So, and I think that's generally fine. It is a really individual discussion to have. There are some risks with HRT. Sadly, those have been really blown up over, in terms of their impact over the last, decade. But it is fine for women to take. Sometimes women start with just a little bit of estrogen. It's a very low risk thing to do, particularly if they're still menstruating. And that can help just take the edge off some of the symptoms they have. So to answer your question, I don't think there's any particular, age or set of symptoms that you need to start HRT.
I'm with you. And Arvind, Joan's mentioned some of the safety concerns about HRT. Could you just explain what they are for me?
Well, first of all, with respect to estrogen, it has a slight increased risk of causing blood clots. So you always have to be very mindful if somebody has had a previous history of getting blood clots in the legs or in the lungs. We know that giving estrogen through the skin is perhaps the safest way of giving estrogen in that particular regard.
As patches?
As patches or as gels or as sprays. Right. But actually the HRT story has been a woven story through the decades, in fact. So in the 80s, 90s, it was a very popular form of treatment for menopausal women. And then sadly, there was a couple of damning studies about HRT which highlighted an increased risk of breast cancer. And whilst those studies were correct in their findings in that they reported this increased risk of breast cancer, there was a general feeling that it was slightly blown out of proportion in terms of what that absolute risk represented. But inevitably, because it hit newspapers, because general practitioners, because gynecologists, women, all began to hear about this, the bottom fell out of any HRT prescriptions, all down to this fear.
Yeah, and I heard about it. And if an orthopod knows about this, then it's pretty widespread.
Absolutely. And so actually that probably set back women's health in general and menopausal health for women many, many years. And it was only maybe in the last 10 years or so that there, again, we come down to awareness and a reappraisal of some of that evidence, whereby actually put into perspective, whilst there may be and is likely to be a small increased risk of breast cancer on women taking certain types of HRT compared to, for example, as Joan mentioned, drinking alcohol or being a much more raised body mass index. Those are far higher risks of developing things like breast cancer. So all of that needs to get thrown into the weighing up of pros and cons and this individualized response that Joan mentioned. But it's chiefly that increased risk of breast cancer that scared people off, as well as being aware of this prothrombotic risk, this risk of getting clots that patients need to be aware and familiar with.
Understood. Thank you. That's really helpful. Joan, how do you approach these conversations with patients who are unsure or fearful about taking HRT?
Well, I think it is a very individualized discussion. I make sure I take a really good history of their family history, any previous imaging they've had, mammograms and breast ultrasounds and so forth, any other gynecological cancer family history that they might have, and then a history of any clotting problems in the past. I would say to women, so the risk of breast cancer in the age group of 50 to 55 is 4 additional cases per 1,000 women. So it's a pretty small number. And, as Arvind said, it's the same risk as drinking 2 glasses of alcohol per day.
Right.
It's much less than the risk of having a BMI of 30 or more, which a lot of women in this age group do.
Yeah.
So again, I always try to put it in perspective for women because there's so many other benefits, and it really isn't just, unfortunately, the discussion has been around breast cancer, black and white answer, can I take it or can't I?
Yeah.
And there's so many other benefits to HRT that they could be missing out on.
So it's a matter of you kind of framing the conversation and individualizing it for each patient. That's interesting. In terms of other treatments, you've touched on a few. Are there any other treatments? I just want to make sure I haven't missed anything.
I mean, there are some other medical treatments that can help with hot flushes primarily. There are a lot of herbal kind of remedies that are talked about that are certainly on the shelves that I think a lot of women try. It's not something that I am particularly involved with, or that it's not necessarily an evidence-based kind of therapies. That's not to say that it's not helpful sometimes for people. And just like Arvind said, from diets that are anti-inflammatory and so forth, sometimes women get benefit and they feel better when they eat better too.
And one thing that's interesting for me, I do treat, women in their 50s, and I take a medical history, and a lot of them are on HRT. And the thing that surprised me is that a lot of them have said to me that it's changed their life. It's been revolutionary. And so it's a shame, Arvind, that it's had such bad press when the positive effects can be so significant.
Yeah, I think that's right. And as Joan said, that often a lot of the women have been suffering with symptoms that they haven't necessarily pieced together to put under the possible umbrella of menopause. And as she's also spoken about, this concept of perimenopause, where there may be onset and subtle onset of these symptoms much earlier than the menopause itself. For a lot of women, when they actually come to the conclusion that potentially they might try some HRT, for a lot of women, it may be a game changer and lead to significant improvements in energy levels, in confidence, in libido levels, as well as some of those general day-to-day symptoms of hot flushes and sweats that they've been struggling with, the tiredness. And of course, it's difficult to ascribe all of those things to hormonal depletion, but we certainly know for a lot of women, it goes some significant way to improving things.
And I guess you're seeing some of the patients that perhaps the younger age scale. And so perimenopause is a thing that I'm hearing about. I don't think I'd heard of it a few years ago. We hear about it increasingly. That's something that's increasingly kind of recognized and discussed. how does that just present? And because a lot of women now around the age of 40, a lot of the mums at school, are kind of, concerned about it, because they know menopause is coming. And so a lot of people are looking for perimenopause and perhaps ascribing symptoms to it that aren't necessarily so. And some people will have menopause earlier than 50. How do you see perimenopause?
It's a very grey area, and it's full of a whole host of symptoms that are difficult to necessarily bracket as saying that they definitely are caused by hormonal depletion. But if we take a step back and we think, what does the menopause mean? And as Joan's explained, ultimately what that means is that the ovaries are no longer working, producing many of the hormones they were producing before. They do produce a small amount of testosterone in the postmenopausal woman, but generally they're not producing the mainstream estrogen and progesterone.
Yeah.
And apart from if the ovaries are surgically removed, that process isn't an abrupt process usually. It's an insidious process.
Just dialing down.
And that process probably happens for some women. And of course, there are some women who reach the menopause early, really early. And that's kind of ovarian failure, where they reach the menopause before the age of 40, who are almost a separate group with a whole host of possible long-term medical problems who need to be diagnosed. But for a lot of women, it's this, as I say, this insidious declining of ovarian function, which may wax and wane, which may intermittently give some of those menopausal type symptoms. So I think, again, if you are suspicious of some of those symptoms, there is a degree of trying to work out, am I going to try and tackle this with lifestyle interventions, with dietary modifications in the way that Joan has said, and these are never going to be bad things to do.
No.
But potentially, if you are continuing to struggle, it might be worth opening your eyes to the possibility of trying some hormonal interventions that may help, but sadly can't be guaranteed to be successful for every woman.
Understood. And I guess that's where, Joan, you might want to do some blood tests in the perimenopause stage, particularly if you think someone's entering early.
That could be very helpful then to try to decipher whether it really is a menopausal or perimenopausal effect, or perhaps other medical conditions, or even lifestyle.
Yeah. And we talked about instigating HRT. Do women ever have to stop HRT?
So this is another thing that I think people find a difficult area in hormone prescribing, because most women, when they start HRT, they think, this is great, I feel so much better, I want to stay on this for, it's like candy, they want to stay on it forever. And I think, again, it shouldn't be, a black and white rule based on, which tends to be based on breast cancer risk. That is there, that does increase as the longer that you use HRT. Yeah. But again, there's lots of other lifestyle effects, benefits by taking HRT. There's benefits to your bone density, for example, from taking HRT. So it really should be just like the initial discussion about having HRT or starting it.
Right.
Whether you continue it would be based on your individual risk and your individual benefits from it. I mean, the previous guidance was always take the smallest amount for the shortest amount of time. Yeah. And I think, well, that's a sensible approach. For some people, they can go on it for a long, long time, and they get other benefits, and they're very low breast cancer risk type patients. And so they would benefit from being on it for 10, 15 years.
That's what I had in my mind, what you mentioned, the lowest dose for the shortest amount of time, because I see people in their 50s on it, and I don't really tend to see people that many in their 70s or 80s on it still. So I'm just wondering whether that's a historical thing where it was just stopped after 10 years, a certain length of time. And is that still the case now? You're saying more and more it's an individualized discussion now.
Yeah, well, I think women tend to be less troubled by the symptoms as their hormone levels sort of, get to a more stable level, and then they can slowly decrease their HRT, and usually, I think a lot of women in their 60s and 70s probably don't need it as much as women in their 50s do.
Yeah.
Well, the alternative interpretation of that, Kash, is that those women who are still on it have got such good bones, they don't need to come and see you.
Yeah, it could be. Yeah, I hadn't thought of that. Yeah, Yeah, gosh, high order thinking. We're going to keep gynecologists out of the studio. And can I just talk about some of the broader health implications? Because menopause will have effect on cardiovascular health, bone health, you touched on, and mental health. How does that present?
Well, I think, this is, and I always try to take this opportunity when I see people, particularly at Cleveland Clinic. We do a lot of women's health screening. And it's really a time of life to optimize your health, because some of the lifestyle interventions are very important for helping menopause, but they're also very important for reducing your risk of future disease. So some of those, your cardiovascular risk goes up during this time period. So you should keep a close eye on your cholesterol, triglycerides, blood pressure, and weight. Lots of people start gaining weight in this time period, putting them at risk of cardiovascular disease, diabetes, fatty liver disease. The other really important thing that's going on that'll be near and dear to your heart is that bone density is, as you know, is on the increase until about the age of 30, and then it plateaus. And then at the menopause, it can start declining again. Obviously, if women have, that puts them at risk of fractures when they're older, and that has huge mortality associated with it. And all of those things are kind of silent conditions. It's not something, the weight you might notice, but there's other effects.
Osteoporosis, you may not know until you get a fracture.
You might not notice your blood pressure is going up. You wouldn't notice your cholesterol is out of range. So all of those things, it's really an important time to optimize and look into those aspects of your health. I think, always, whatever age you are, mental health is, of course, very important. It tends to be a really relevant time to look into that. And as I said before, doing things like managing your exercise and your sleep and making sensible commitments to others, it really does help people with their mental health as well.
And are we seeing improvements in the way women's hormonal health is approached, or is there still a long way to go?
Oh, I think there have definitely been improvements in the last, every year it gets even better. There's more and more awareness. I think there's more research going on. I think there's research going on into the cognitive effects of the loss of estrogen, which is all a great thing. So there's a lot to still understand, but I think there's been a lot of attention paid to menopause in the last decade since that study came out. And unfortunately, I think many more women have access to HRT and treatments for it.
Thank you. I'm just wondering, as we kind of get towards the end, how can women better advocate for themselves in a system that doesn't always hear them?
I think, that's an interesting question. I think in the last even 5 years, I think a lot of times if women went to their GP, they wouldn't necessarily walk away with a prescription for HRT. And that has really, really changed. And I think they should feel empowered to go do that, because it is a much bigger opportunity now than it used to be. There are other things that the government has done. They give prescriptions for HRT. There's a certificate you can get, so you only pay £19 a year for your HRT. But I think, to answer your question, I would hope women could listen to podcasts and do a little bit of reading, and certainly talk to their GP or their gynecologist about the symptoms they have, and try to decipher what the best next steps are in terms of treatment or not, or watching and waiting.
Thank you. Arvind, what role can men play as clinicians, as colleagues, as partners in supporting women's health better?
Yeah, I was encouraged to hear what Joan's take was on women's health. And I agree that certainly there have been certain improvements in initiatives that are out there in terms of awareness of menopausal health. We spoke about endometriosis previously. I kind of like to kind of rattle on the cages a bit more, because I think there's still a substantial way to go in all of this. I don't think it's exclusively down to kind of men or women sort of thing. I think that there is just certainly a need for awareness across the board about women's health and the some of the conditions. So we've mentioned the menopause, we've mentioned endometriosis. I think that awareness of those kind of conditions is really important, and that's where it starts, I think, an awareness. But I think we still fall short of many things for women in terms of, if we look at the waiting lists for them, and they're disproportionately high for women waiting for gynecological surgery. So I think there are many levels, from a kind of domestic family level, from schooling all the way through universities, areas of employment, government. There was an all-party parliamentary group on endometriosis that highlighted some of the kind of concerns. So I think that working together on these things, but also pushing on them to kind of say, well, look, why are we still falling short in today's world? Why are we still falling short in the care that we offer women, is a message that we shouldn't kind of withdraw from, despite the fact there are improvements. And some of that, again, as I said, comes down to charities, to national bodies, all of which we try and get involved with to kind of push the cause.
And it's interesting, you're talking about women's health, but on a broader, I keep bringing it back to knee surgery as a knee surgeon, but there's been an epidemic of women's ACL ruptures, particularly in professional footballers, over the last couple of years, and that's been very much in the similar way that you mentioned. It's become much more recognised, much more promoted, and so and now they're looking to make boots that fit the female foot, giving them better training opportunities. If you look at the weight rooms for women's team versus men's team, the facilities, they're not remotely the same. The quality of the pitches. And so I think what you're talking about is it's a systemic change that's needed. You mentioned some of the helpful resources, charities, website support groups. Are there any for endometriosis that you would suggest people go and look at?
I think for endometriosis, and actually often my patients are almost more savvy in terms of what's going on online than I am. I am part of the British Society for Gynaecological Endoscopy, so that's often a good resource for clinicians. With respect to endometriosis, there are endometriosis charities, Endometriosis UK, the Endometriosis Foundation, to name two of the charities that are out there, all doing good work, all spreading the word in many different ways. So, and also the NHS has some online tools as well that are useful.
And Joan, for menopause, are there any things that you would signpost people to?
Certainly the British Menopause Society is a really helpful, really comprehensive set of information about menopause. I think the NHS, Cleveland Clinic London, has some really good information, or Cleveland Clinic Ohio, about menopause as well. So I think what's difficult is that there's so much out there now. It's kind of you can get on a wild internet goose chase. But so yeah, I would sort of stick to sources like that.
Okay, thank you. And we'll put some links in the show notes. So we've discussed some incredibly valuable information today. My key takeaway is that I would encourage everyone to share this episode with women in your lives, or to raise these issues with your doctors now that you have this information. Just to wrap up, you've been listening to Exploring Health with Cleveland Clinic London. It's been a pleasure to have Joan and Arvind with us today. Thank you very much for sharing your insights. If you've been listening or watching and you want to take charge of your health, please check out the links in the show notes for more information, or go to the Cleveland Clinic London website. If you found this conversation valuable, please don't forget to subscribe, leave a review, and share this with someone who you think needs to hear it. Until next time, thank you.